Today, Katrine and I will be focusing on readmissions, which is a big quality and safety problem in nursing. You don't want your patients to be coming right back to the hospital after they're discharged.
Readmissions to the hospital are a reason for concern for several reasons. Readmissions put stress on the healthcare system financially. Readmissions are a result of poor patient care, which means there's a need for quality improvement. Readmissions means there's a poor outcomes regarding health longevity due to poor follow-up and poor health maintenance abilities. Readmissions means there's a lack of ability for identifying risk factors for readmissions. And most importantly for the patients concerned, readmissions result in a revolving door phenomenon, which means patients are constantly in and out of the hospital. This problem was recognized nationally by the National Quality Forum. They made readmission prevention the #1 safety goal. The National Quality Forum did this because they recognized that poor discharge follow-up led to 1/5 of Medicare patients being readmitted within 30 days of discharge. Driven largely by poor discharge procedures and inadequate follow-up care, readmissions are cause for concern because all insured patients have preventable readmissions of 11%, while the rate for Medicare patients is even higher at 13.3%. In terms of history and for some background on readmissions, the Kaiser Family Foundation plotted a graph showing readmission rates focusing on major readmission-prone diagnoses like heart failure and myocardial infarction. The statistics show that from 2005 to 2014, there was a downward trend in readmissions rates starting in 2012. HRRP guidelines are what are responsible for this trend because this graph shows when their financial penalties started being introduced into action. So strictly speaking, it seems readmission rates have decreased because financial penalties for hospitals with high readmission rates were put into action. In terms of the HRRP history, they have been steadily increasing the penalty hospitals are subject to for high readmission rates every few years. You can see they have also added to the list of diagnoses that are identified as having higher readmission rates and risks, such as COPD and hip and knee replacements. This penalty, you can see, did cause a decrease in readmissions by making hospitals fear financial penalty. Utilizing the QSEN competencies to reduce readmissions, we're going to review the aspects of the QSEN competencies in order to see how they would target readmissions. So patient-centered care recognizes diverse patient populations and the need for individual needs assessment. It allows the nurses to not only recognize individual risk factors that can contribute to readmissions, but also creates patient-specific rather than general care plans to address individual unique circumstances. This allows for identifying the factors in this patients can help for nurses to formulate a plan to prevent readmissions in a higher risk patient population. In terms of teamwork and collaboration, interdisciplinary action are necessary to keep readmissions from occurring. Collaboration with inpatient and outpatient treatment plans allows for continuity of care and discharge to promote well-being and prevent readmissions. In terms of evidence-based practice, using evidence-based results on how to prevent readmissions allows nurses to utilize up-to-date modes of actions in their interventions and patient encounters. In terms of quality improvement, identifying and acknowledging problems of readmissions allows there to be a system-wide effort to be made in order to promote more effective care before discharge to prevent readmissions. In terms of safety, advocacy for patient safety and proper care technique can eliminate errors that could potentially lead to patients to have readmissions. And lastly, for informatics, using trends found about patient readmissions to identify high-risk patients and situations, we can use that information to play an active role in preventing readmissions by monitoring patient outcomes and inconsistencies.
The Joint Commission is an organization that implements the QSEN values and focuses on the hospital system as a whole. The Joint Commission created the robust process improvement method that can be applied to readmission reduction. They are working to reduce hospital readmission rates by finding gaps in the hospital system as a whole, individualizing patient care and risk assessment for each patient. They want to create a proper discharge process that's unified for the entire hospital and the entire hospital system. And they want to engage the family and the interdisciplinary healthcare team in the community. So basically, they want to identify systems errors and maximize the system functioning of the hospital as a whole. Project RED was developed in conjunction by the Joint Commission and the Agency for Healthcare Research and Quality. Project RED, which stands for Re-Engineered Discharge, is an intervention implemented in a patient-centered, standardized approach to discharge planning and discharge education. It's aimed at improving the patient's preparedness for self-care and at reducing the likelihood of readmission. So basically, they provided technical assistance to 269 U.S. hospital organizations in 30 different states, and they implemented these interventions. So the components of the RED intervention that was implemented are as follows. The first one is to ascertain need for and obtain language assistance. So you'd want to eliminate that language barrier. The second is to make appointments for follow-up medical and laboratory appointments. So if the hospital and the providers help the patient to do this before discharge, it can really help them to actually go and attend their follow-up appointments. You want to plan for follow-up for any labs or studies that are pending upon discharge. So this is any labs or studies that you haven't gotten the results back before the patient's discharged. You want to organize post-discharge outpatient services and medical equipment. You want the patient to be prepared to go home. You don't want to send them home into an unsafe environment or without the equipment that they need to be safe. You want to identify correct medication and ensure the patient can obtain and correctly take medication. You want to make sure that their pharmacy is ready and that they know how to take their medication. You want to reconcile their discharge plan with national guidelines, so this goes back to that unified system. You want to teach them a written discharge plan and make sure that they can understand it. You want to educate the patient about his or her diagnosis and the treatment as well. You want to assess the patient's degree of understanding about the discharge plan that you're putting out there for them. You want to review potential complications that the patient should be aware of and what to do in the situation of an adverse complication. You want to expedite transmission of discharge summary to the provider taking over care of the patient. So this is likely the primary care physician. You want that continuity of care from the hospital to the primary care provider. And you want to provide telephone reinforcement of the discharge plan. When they go home, you want to make sure that they're still understanding what they should be doing and looking out for. So there was a study done to identify the risk factors in general surgery patients at Emory University Hospital. So a lot of the patients who are being readmitted are people who have come out of surgery. In the study, there was an 11.3 readmission rate within 30 days of discharge. That's more than 1 in 10 patients. The 3 most common reasons for readmission were GI problems and complications at about 1/3, surgical infections 1 in 5, and failure to thrive or malnutrition. This is highlighting that post-operative complications are the driving cause for readmission in surgical patients, and it is key to educate patients about identifying the signs and symptoms of adverse complications from surgery. You want them to be able to catch a complication before they have to be readmitted to the hospital. The next study was a meta-analysis of interventions that
evidence-based practice recommendations suggest that reducing readmission rates from a patient perspective includes improving core discharge planning and improving transition processes. This acknowledges the idea of having increased follow-up care, identifying high-risk patients, and promoting patient education. So one of the things that Kaiser family kind of put together was an ongoing follow-up care for high-risk patients. So first is the idea of pre-discharge risk screenings. This is identifying the high-risk patients from the very beginning. The second is hospital visits with a wellness coach, which allows the patient to kind of understand what their high risk is for and instead have a common connection to a wellness coach and kind of talk through their own experiences with them. 3 is home visits with wellness coach, which again decreases readmissions because when they're outside of the hospital, they don't feel like they have to go back in because they have that extra resource outside. And 4, ongoing follow-up care for up to 3 months. Again, this allows for the patient to feel comfortable outside of the hospital while still receiving the care that they feel like they should get. Further recommendations for best practice include really focusing on education, which is 1, identifying the key learner, so identifying which patient really needs the education. 2, evaluate the learning, so using teach-back methods. 3, create a culture supporting education, meaning everybody on the unit should be promoting education and the patient should feel comfortable while getting educated. 4, adopt a system to make it seamless. This means the unit should understand that certain patient populations need more education and to make it a standard of care. And 5, provide patients with well-developed materials. Meanwhile, other evidence-based recommendations include 1, enhance care and supporting during transitions, which means that when they're going from inpatient to outpatient, they have that support that they need so that they don't feel like they have to return right back to the hospital. 2, improve patient education and self-management support, which means the patient feels more empowered to provide care for themselves. 3, multidisciplinary team management. This is again working with both inpatient and outpatient care teams in order to make sure that the transition from inpatient to outpatient for the patient is good and they feel empowered during that time and don't feel like they have to go back to the hospital. And 4, patient-centered care planning at the end of life. STAR, or the State Action on Avoidable Rehospitalizations, was an act that was from 2009 to 2013 that was a 4-year plan. And though this happened before 2017, it kind of focuses on two key aspects that are very important at the state level rather than the patient level. So one is to improve transitions of care by cultivating a cross-continuum learning collaboration, and two is to engage state-level leadership to understand and mitigate system barriers to change. And this kind of addresses the ideas at the state level rather than in the hospital level, so changing policies in order to help reduce readmission rates. The Kaiser recommendations for the best practice focus on the role of HRRP systems, which involve reevaluating the HRRP guidelines to target the correct type of readmissions. This means focusing on unplanned and related to the initial admission readmissions and not planned readmissions that unfortunately get encompassed in that. So the recommendation is to focus on the specific kind of readmissions that the HRRP wants to address. The next recommendation is the HRRP acknowledging the size of the hospital because smaller hospitals receive the same scrutinizing and penalizations as the larger ones, which can inhibit the smaller hospitals more severely and rather than promoting better patient care. Last is identifying high-risk patients, which means further understanding health comorbidities and identifying diseases that are more likely to contribute to higher readmission likelihoods with the HRRP monitors. In terms of connecting this back to the Georgetown NHS values, we decided to focus on excellence and the value of the common good. In terms of excellence, displaying excellence in one's work allows the nurse to ensure that the quality of care the patient is getting is high. By providing good care and good discharge along with patient teaching, it can reduce the amount of hospital readmissions.
So another of the Georgetown NHS values that can be emphasized in reducing readmission rates is the value of the common good. It is important for the well-being of the patient and the common good of the patient's family and friends, the providers, the interdisciplinary healthcare team, and the hospital organization as a whole to lower readmission rates. You're looking out for people who are marginalized because often people who are readmitted are people with multiple comorbidities or at some disadvantage, such as a low health literacy, low socioeconomic status, a poor understanding of their disease and treatment, or bias related to having multiple health comorbidities. Don't come back. Don't come back.